Because adversity is often the breeding ground for development, dive into Neurointerventional Stories, the uncensored interviews. Our guests, all leaders in the field of neurointervention, share the difficulties they face, the complications they have had to manage, and speak without filters on little discussed, sometimes controversial, or simply taboo subjects. Hi everyone, this is Dr. Sujijantarat again, and today I have the pleasure of being with Dr. Jan Gralla from Switzerland. He is a professor of neuroradiology. He's a director and head of Department of Diagnostic and Interventional Neuroradiology at the University of Bern, Switzerland. Welcome here today.
Thank you, Nan. Thank you.
So we know you now as one of the influencers in the field. So take us before all of that. Who were you? And you can go as far back as you want.
He grew up in northern Germany, in fact. My father was a neurologist, and he took me all over the world when he was traveling. And I thought medicine is a good thing to study, and I was actually focusing on tropical medicine. So when I started studying medicine, I thought I'd become a specialist for tropical medicine diseases. And then I started to study and find out this is actually part of internal medicine, which is not very interesting. So I came back to the idea of neurology, neurosurgery, neuroradiology, and I decided for neurosurgery. Finished medical school in Göttingen, and then went to a well-known neurosurgical site in southern Germany, Bavaria, Erlangen, a large neurosurgical hospital, and started there in 1999, so quite some time ago. During the time of my education, I was focusing on vascular neurosurgery, and then the disruptive business suddenly came, which was coiling. So coiling aneurysms came up, and the most important one was probably the ISAT trial from Oxford at the time in 2002. And I looked at this trial, I was at a scientific interest, and it was pretty clear things are changing. So 2002 was the turning year in my career when I said I have to have a look at interventional neuroradiology or endovascular neurosurgery, and then went to Switzerland. My first time in Switzerland. Started my training there. I had to repeat radiology from scratch. That was quite painful. As you can imagine, looking at thousands of X-rays of the chest was not exactly in my intention. And then went to Oxford for 2 years, 2006-07. Started my endovascular training there, went back to Switzerland, and then continued my career. Now I'm Diagnostic Interventional Neuroradiologist, as this is called in Switzerland. So in a nutshell, this is from child till today.
You pivot early and at a good time as well. This is even before all the stroke stuff become a thing.
Absolutely. No, absolutely. I think that was, from my point of view, this is the turning point between vascular neurosurgery and endovascular neurosurgery or interventional neuroradiology. The turning point was 2002, the first randomized controlled trial, evidence-based medicine on an endovascular approach for common disease, and then things fall into their place over the time. So yes, stroke treatment make a big difference, but at the same time, everything has increased. So, and we're treating more and more diseases, MMA embolizations, intracranial stentings, and so on. And so it's a growing field, massively growing field.
So let's go into that. Can you talk to us about the Stroke Research Center at Bern? You are a director. What was the impact of this work on how stroke is organized in the region?
There is a national level in Switzerland, and obviously then there's a local level around Bern. And we picked up the topic of endovascular or more advanced stroke treatment early. There was a tradition, even before I came to Bern. The head of neurology and the head of neuroradiology at that time, they started in the mid-90s to do intra-aortic thrombolysis. So this was established to some extent. On the national level, we started in 2012 to roll out the map to define what is a stroke center, what is a stroke unit, and which stroke unit doing IV thrombolysis, sending to which center for mechanical thrombectomy. So this was organized early, and I think it's well organized in a small country. So that's easy compared to other places in the world, and also good infrastructure. So no large remote areas where you have to fly over for 2 hours or 3 hours. And then the local network, that's always a question of continuous education. In the hospital, to have new anesthetists working with you, around the hospital to have new sites or new people at certain sites to send patients. But what we do, and I think that's probably quite a good way of dealing it, at least in Switzerland, is we talk to them on eye level. We invite them once a year, all the centers, to Bern, and then discuss what the results of the treatment was of their patients, not of some patients, how we can optimize the workflow, what kind of imaging would we like to have at their site, what is the best transport system to get the patients in. From the mountains, it's helicopter, but otherwise it's maybe by car, for example. So this is the way we organize it, and I am in the lucky situation that the discussion with our neurosurgeons and neurologists, or the neuro center, is a very, very nice, evidence-based, friendly discussion. So we really organize things together.
That's wonderful. Now, you are a PI for a SWIFT direct trial, which shows that direct mechanical thrombectomy fails to show non-inferiority compared to the bridging thrombolysis and mechanical thrombectomy. You are also involved in stroke with mild or rapidly improving symptoms. You're also involved in a Distal trial. I'm curious to know, what was your first PI experience? How did you get into trials, and how do you advise those who want to be more involved?
I think the first largest scale study was with a very good friend of mine, Vitor Pereira, who's actually organizing Link here as well. That was a funny historical setting, because in 2012 we had negative trials for endovascular treatment of stroke. At the same time, stent retrievers were around, and we saw that stent retrievers are very, very efficient for recanalization, and they have not been taken into account for these particular trials. So we're expecting the negative trials, and at the same time, we said we would have to have a study as fast as possible. Single arm, consecutive patients, core lab control, just stent retriever cases. So we can present the results of stent retrievers at the very same meeting that was IDS International Stroke Conference at that time, to show in comparison to this negative data something which is a new development, which is completely different. And we managed to do so. So if you ask me what was the first study experience, it was sitting with Vitor until 4 o'clock in the morning, reviewing everything under the timely pressure that we have to present 3 days later after the lock of the database. So what I would recommend is you have to be aware that a trial is a lot of work. The study protocol is absolutely crucial. Jan Gralla once said a randomized controlled trial is like nuclear energy. It can be clean or it's a disaster. It's one or the other. And you see trials which are a disaster simply by the design. So design is crucial. And then you need a lot of endurance. You have to have a certain frustration tolerance in running trials, because in the beginning nothing happens, and then it's exponential growth.
I'm curious to know, having been involved in Distal, how have these results changed your practice today, and what do you think we'll end up doing in the long run for these M2s?
We've been one of the contributing sites as the study came from Switzerland. Obviously, we enrolled into Distal. But MEVO and Distal, both trials, obviously did not show what we expected them to show. I guess there is a study design and cherry-picking problem in both trials, so it does not really reflect what we see clinically. Nevertheless, I was asked about a year ago in an interview, what do you think is the outcome of these two trials so far before they were published? And I said, either way, I'm not going to be happy. Because the very proximal ones, like M2 occlusions, they are definitely target for mechanical thrombectomy. On the other side, the very distal M3, supratrunca's elongated vessels, I'm not happy to treat them at all, because I think they have a complication rate. Did they change management at our place? No, it did not. Because we've been always reluctant to treat in certain locations, tiny vessels, M4, elongated vessels, tiny infarct area, tiny hyperfusion, and we've always been very aggressive proximally. But what we will see is probably a change in the referral pattern. So outside, people might react differently, referring centers might react differently than we would react internally. So do they change our practice? Probably not our attitude of who needs to be treated, but maybe the referral pattern. So I think we will see a certain decrease of stroke patients coming to our place. If you look at the population that has been investigated in the trials, it's quite a broad population. And within this population, you can still say there must be some expert opinion to decide whether you go or you don't go. And the same expertise has been taken into account by enrolling patients. Some have been enrolled, some have not been enrolled. This is exactly the cherry picking. So from my point of view, what we try to establish again in our stroke network is call us, ask us. We know the study results as well. We're going to be more reluctant than compared to before, but there are good candidates.
What do you think is the next frontier in stroke care or stroke research?
In stroke care, I wonder where the journey goes. I think endovascular stroke treatment in large vessel occlusions, mechanical thrombectomy, is tremendously successful. So if you look at the TICI-2B3 rates, for example, of Swift Direct, where I was in fact a co-PI. The other co-PI is Urs Fischer, the neurologist from my place, to be fair. And the recanalization rate above 90%, TICI-2B3. So how can you possibly improve this? And I think there's our observational point is wrong there. We have to change from TICI-2B3 So taking TICI to be 3, C to 3, into 3 or non-3. In other words, you either recanalize completely or everything else is not good, because there's a tremendous clinical difference. So if you look at it from this perspective, there is room for improvement, because TICI 3s, true TICI 3s, with no distal embolus, are much rare. Swift direct again, about 33%. So I think if we go for developing different devices just from the pure mechanical point of view, we're going to consider non-TICI 3s as not optimal, or even as a complication in the future. And then there is room for improvement. Where do I see something that is on the horizon? I wonder what cyclic aspiration will do. I think cyclic aspiration, what I saw on benchtop models, is quite impressive. That could be some sort of a game changer to get TICI 3s, prevent the non-TICI 3s. Personally, I'm starting to shift away from acute stroke research. The group itself in Bern, they do brilliant work all the time, and the neurologists are very busy. Our young fellows do a lot of research. At the same time, what I was interested in for quite some time, also from the technical point of view, is chronic total occlusions, CTOs. They've been treated everywhere in the body for quite some time. We all started to treat cervical, ICA, chronic occlusions. And they usually extend to the P2 segment, and you go and you canalize with certain wires and certain devices. I think there's some potential in there, because the alternative is either best medical treatment, which is not very successful, or bypass surgery. So I think there's room for us. And I personally started to recanalize intradural chronic total occlusion, so intradural CTOs, which is a bit more challenging, because obviously if you perforate, you have a different consequence. It has to be done this very carefully and with good machinery, good devices, good angios. But it seems to be possible, and we're actually running a retrospective study on this. It's called ReChill. One of our colleagues, Petra Zimflova, is in Bern's responsible for this. We're starting to pool patients from all over the world retrospectively to see what are the indications for this treatment, what is the complication rate, and what kind of technical devices give you a certain success story in this.
Just to get into the weeds a little bit, because this is something that does come up a lot in clinical practice. We have someone who has a chronic occlusion or chronic severe stenosis that went into acute occlusion, who is symptomatic and perhaps has hypoperfusion symptoms. That would be someone that at your center would get treated.
Absolutely.
Okay.
Absolutely.
Acutely.
Mm-hmm. Acutely. If you look a little bit back in the history of high-grade stenosis, intracranial stenosis, for example, then we have Sempris. Sempris was the nuclear bomb, wasn't it? Stopped basically the treatment or the intracranial stenting for symptomatic intracranial stenosis. At the same time, patient selection were not the hyperperfused ones. So there is definitely room. We all left this sort of field behind or forgot about it for some years, but the problem is still there. It's in Europe, but it's especially in Asian countries with a much higher frequency of intracranial and symptomatic intracranial stenosis or occlusions. So I think now is the time to revisit this. There are other studies like Reboot to look into different treatment strategies like PTA only, PTA plus stent. From my point of view, with the new stent developments that we have right now, also coated stents, which are less thrombogenic, also to some extent with our own expertise that has grown in the last 10 years. I think we are on the way to succeed on these intracranial symptomatic stenosis. May they be with hyperperfusion or even without, and also on occlusions.
Yeah. I recently reviewed an article, and I think I can talk about it now because I think it's already out, where they were looking at the number of publications that came out about ICAT, and if you look at the chart, it's exponentially growing, and it's such a field with so much room to improve. So just one last question in the weeds. What about chronic severe stenosis extracranially, but you see that there's no alveo? There's flow across the ACOM, everything fills. Would you go after something like that if they present with acute symptoms?
If it comes in the setting of the acute stroke, it really depends, because obviously the patient got symptomatic at one point, otherwise we wouldn't have found it. Right. So there might be something. And then it really depends on the clinical symptoms on the imaging. If the patient is sort of fluctuating between 0 and 4 on the NHSS, then obviously the hyperperfusion might be limited, and one could wait and see. Keep the patient on the ward, increase the blood pressure. But very often if we see infarct areas already, especially watershed infarcts, and you would do follow-ups and then you see growing watershed infarcts. So in those cases, we would rather go and treat. Depending on what it is, in tendency for occlusions we would, For dissections, it's a bit different because the healing tendency of dissections on their own, by having them on heparin or aspirin, is very good, and the complication rate long term is low. But in tendency, if you ask me what would you do, in tendency we are quite aggressive to recanalize.
It is such a hard concept, I think, for at least for me to grasp, because to me, if everything intracranially is open and you have a problem of either severe stenosis or occlusion extracranially, then the pathway of trying to figure out what to do kind of follows the carotid stenosis pathway, which tells us that we don't touch things that are hot. And so I think this is going to be kind of a paradigm shift, so to speak, in the way we learn about things.
Yeah, that's one issue. And the second issue, obviously, is in those patients, there's not a lot to win. If the patient is within an age of 2, 3, 4, the patient will not be severely disabled, most likely, but there's a lot to lose. So these are, to some extent, high-risk interventions, because if something goes up, then you suddenly have your intracranial occlusion. I was invited to give a complication presentation here yesterday, and it was actually about something like that. Yes, most of the times it'll be fine, but you have to be aware when you, with the best of your knowledge, if you go into the case, that there is a certain percentage of patients that you do harm by recanalizing cervical vessels. If something goes up, you have to be able to get it out, otherwise you have a mess. So yes, reluctant, but wait and see does not seem to be the best strategy as well.
Let's shift gear a little bit. You are involved in device development. I'm curious to know, how did you get into that field and what was the impetus for that?
Mm-hmm. Well, being around for quite some years now, so I started in interventional neuroradiology in 2002, so I was involved by companies looking at the prototypes in the beginning, giving advice, consulting on certain aspects of stroke or aneurysm treatment. And that was interesting. I was also a bit more involved in R&D with some company, and it has always been nice and cooperative. At the same time, I always got the impression it would be nice to follow it from scratch. There was one idea, I was walking around for quite some time, to basically replace metal coils by polymer. That was the principle for everything, sinus occlusions, if needed in AVMs, definitely for large aneurysms and so on. So I reached out to a polymer expert. We reached both out to a friend of his who did this before, taking care of startups. And the three of us are currently investigating and on the ideation and patenting period. And you never know where a startup goes. I mean, to 95%, it'll go to the junkyard. That's the fate of a startup. At the same time, it has been very, very inspiring to do something else than the classical way of research. It's sort of the manual, and ideation research is completely different than writing a study protocol.
Right. When we were doing pre-interview questions, you said that dural AV fistula is your favorite intervention. Why is that?
At our center, we have like 400 strokes a year, and I'm involved for many, many years. So you can imagine I saw many, many strokes at any time of the day, of the week, and the year. And they can be very interesting, and most of the times I enjoy them. At the same time, it very often is kind of repetitive work. The M1 occlusion is quite repetitive work. It's pretty much the same on Monday noon as on Sunday 2 o'clock in the morning. And the joy for the two cases is different, however. There are a couple of very individualized diseases. So complex aneurysms are very individualized. Not standard treatment. You really have to have a standard treatment plan. AVMs, highly complex. And durofistulas, the appealing thing here is very often, if you reach the fistula, if you identify the fistula point, which might take some time, if you're able to get there transarterially or ideally transvenously, and you occlude the fistula point, the huge Borden type 3 AV fistula breaks into pieces, is occluded immediately. And I always thought this is a very appealing thing. It's just a very strategic point to reach. You have to have a very good plan. I really enjoy them. I enjoy type Borden 3 fistulas, occlude the sinuses, get into the sinus, get the fistula point. So for some reason, I like it a lot. I like the planning. I like the procedure itself. Probably also because the complication rate is pretty low. So a patient has severe symptoms, has probably bled. You come from the venous side, and when the patient wakes up, you get what you did. With AVMs, you never exactly know what you get.
It takes a little bit of time.
Or you
figure out,
3 days later, you know that the patient is fine, but you might have a big surprise when the patient wakes up already. So, and durofistulas, by the end of the procedure, you can smile already.
We're in a process of getting this case report published, and we're not going to take credit for this at all. This is something that other people have done, where we took a microcatheter and we did venous manometry of these fistula because someone came in with a very severe papilledema, very severe visual symptoms from high ICP, and has a dural AV fistula associated with stenosis of transverse sinus. And then we stented it because we kind of went back and forth whether we should embolize the fistula. It's going to take a while to take down the ICP. We stented it and then found out that there are a bunch of people that stented it. And so now I'm kind of in this intellectually, again, crisis mode where I'm questioning myself whether I really understand how dural AV fistula works, especially when they're associated with those stenosis like that. Should we be taking them down, or should we be doing a sort of reconstructive approach, like stenting the dural leaflets together? The patient converted to Borden 1 and stayed Borden 1, and the symptoms went away completely.
Exactly what you're describing is what is so appealing. You have the arterial inflow, you have the venous recipient, and then you have the venous outflow. The grading of the fistula is mainly dependent on the venous outflow. Well, it is the venous outflow. So if there's a big sinus, you have a type 1. If the sinus gets stenotic, you get a Borden type 2 because you have reflux. And then maybe it occludes and only the cortical veins are patent, then you get to type 3. So yes, the venous outlet makes a difference as well. But exactly what you're describing is so interesting. So many things that you can do to treat a fistula. Probably one disease which has been very nicely investigated by two of my colleagues, Eike Pichowiak and Thomas Strobotsky in Bern, is a low CSF symptoms. They have a grading scale for this called the Bernese score. And there's a similar disease. So you have different reasons why you lose CSF. It might be a bony spike from the spine. It might be a rupture of your root nerve sheath. Or there might be a CSF venous fistula. And we're quite a busy center in Europe to investigate them and embolize them. And many of what we have said about durofistulas accounts for them as well, although nobody knows how they develop. But it's an inspiring new field with some similarity to durofistulas.
I have to say that I've never encountered them at all, but I feel like they must be one of those pathologies that if you don't look for them, you don't see them.
Yeah.
You really have to look for them.
Absolutely. Yeah. And I started with one of our neurosurgeons a couple of years ago to investigate those patients. And he always said there is a description of CSF venous fistulas. I said, no, I don't even believe that can exist. How can the CSF go into the venous system? Otherwise, you would have an SAH if you cough. So it doesn't work. So it must be more complex than that. No, you really have to search for them. Very often you can't see them on a normal myelogram. You have to do a DSA myelograms or subtracted images or a CTA or CT myelography. And then you can spot them and they exist pretty clearly. You can embolize them, you can operate on them. And it's a very interesting pathology and probably the whole complex of symptoms highly underdiagnosed.
We are nearing the end of our podcast, so we have 3 questions that we ask all the guests that I'm going to ask you today. So the first one is, if we have to choose 2 people who have been the most influential in your career, who would they be and why?
The first one, I think I mentioned it indirectly already, is Andy Molyneux, the global PI for the IZ trial. I think it's completely underestimated what this trial did. It changed everything. From my point of view, this is the first time to create a randomized controlled trial evidence for endovascular treatment. It changed my career for sure. It changed the way that I came from vascular neurosurgery to interventional neuroradiology. It changed my career that I then decided to go to Oxford. At one point, IZ office was in Oxford. So I think this is probably very influential for me personally, but also for the whole field. Second one is a bit more tricky. I think a couple of people that are always interventionalists, neurosurgeons, are always admired for their vision. Just to give you some names, Nick Higgins, Cambridge, venous stenting for intracranial hypertension. A friend of mine, a neurosurgeon from India, Sanjay Behari. Other people. And the impressive thing, and that was influential for me as well, is you come from an observation, intracranial hypertension and sinus stenosis. You think about the pathophysiology, you come up with a treatment, and you persist. And this is exactly what happened there. The first time it was presented, everyone was laughing. And now we all do it. And this is how neurointerventions developed, from the observation and then understanding the disease and try to find a interventional way of treating this. And then persisting, despite the fact that everyone laughs at the beginning. A couple of good examples of this in medicine. For example, the 2 physicists inventing the MRI were unable to publish their results at the beginning. 2006, they won the Nobel Prize for it. So you really have to persist. You have to be persistent in interventional neuroradiology to untangle new diseases.
And if we fast forward 10 to 15 years, how do you imagine the field will look like?
That is a tricky question. If you would have asked me 10 years ago or 20 years ago, when I actually started 23 years ago, I wouldn't have anticipated this. So what has happened in the past, I wonder if it continues exactly in the same speed. I was very heavily involved in the development of mechanical thrombectomy, and that was, from my point of view, once in a lifetime journey. I don't think we're going to have such a breakthrough again. At the same time, if you look at the field, we already touched CSF venous fistulas. We talked about intracranial stenting, MMA embolizations for coronary subduals, chronic occlusions. So there are a couple of things coming up, partially because we are extending our expertise, partially the devices are getting more and more sophisticated. From my point of view, in 10 years from now, we are probably on the path as cardiology was, starting with the interventions, but basically expanding the field to various different territories into maybe functional treatment as well. New targets from my point of view, which will decide how the journey goes the next 10 years, will be tumor embolizations, maybe even transvenous shuntings, transarterial embolizations, and evacuations of chronic subduals. So a couple of good initiatives going on and new projects going on. At least I can say for young people going into neurointerventions, you won't be unemployed. It's a moving field, it's an expanding field for sure.
And the last question is, what is the one thing you would advise our trainee to do today to make them a more successful and better interventionalist tomorrow?
Let's put it this way. What are the key success factors to become a good neurointerventionalist? You have to have a good education, which means you have to go to a site with lots of cases. I think this is crucial. And then if we stick to this side issue, a broad spectrum, a friendly environment, which means you have to have a very good collaboration within the team, but also with neurologists and neurosurgeons. I think this is absolutely crucial because if the indication is clear, for example, if you decide in a stroke in the night to do mechanical thrombectomy, then it's a team approach and everyone has to live with the results. May they be good, you celebrate together. May they be bad, it's a team decision. And that is absolutely crucial, I think, also for yourself and your self-well-being, because nothing is worse than being blamed for a complication, for example. So this is an environment that is absolutely crucial to grow. And then my third point, always coming back to the center, is if you want to be an interventionalist on a high level, you should bring some scientific interest as well. From the personal point of view, a certain way of self-reflecting what you're doing. I think this would be my recommendations. Quite a lot of them, but the most important one might be, where do you go and what can you do? You can observe 10 cases, which equals assisting one, and you can assist 10 cases, which equals doing one.
Dr. Gralla, thank you so much for your time today. It's been a pleasure.
Thank you much.